Surgical site infection, an infection that occurs after surgery in the part of the body where the surgery took place. Categories of surgical wound: clean, respiratory, alimentary, genital, or urinary tracts are not entered during surgery. Clean contaminated. Respiratory, alimentary, genital, or urinary tracts are entered under controlled conditions and without unusual contamination. Contaminated, significant interruptions in sterile technique or gross spillage from the gastrointestinal tract. Dirty or infected, old traumatic wounds with retained dead tissue, and those that involve existing clinical infection or perforated viscera. Surgical prophylaxis, adults and children. Prevention of infectious complications by administering an effective antibiotic before exposure to contamination during surgery. Most likely pathogens depend on the anatomical site of the procedure, often bacteria belonging to the human microbiota. Most pathogens associated with surgical prophylaxis, according to type of procedure. Cardiac procedures: Staphylococcus aureus, coagulase negative staphylococci. Non-cardiac thoracic procedures: Klebsiella pneumoniae, Moraxella catarrhalis. Appendectomy: Escherichia coli. Hernia repair: Enterococcus streptococcus. Gynecological procedures: Staphylococcus aureus, Streptococcus egalaxy, anaerobes. Ophthalmic and orthopedic: Staphylococcus aureus, coagulase negative staphylococci. Urological procedures: E. coli, Enterococcus. Gastroduodenal: Enterococcus enterobacterales. Antibiotic prophylaxis before surgical procedures. The choice of antibiotic prophylaxis depends on the type and location of the anatomical surgical procedure. Patients colonized with multi-drug-resistant gram-negative bacteria. Lack of high-quality evidence to support the expansion of antibiotic prophylaxis. Decisions are usually made on a case-by-case basis. Patients colonized with MRSA who will have a skin incision. Consider adding vancomycin to the routine recommended surgical regimen. Timing of antibiotic prophylaxis: 120 minutes or less before surgery, single dose before surgery. Consider additional dose only for prolonged procedures or severe blood loss. Notes: all dosages are for normal renal function. Gentamicin should be given in combination with metronidazole because, if given alone, it provides insufficient coverage of anaerobic bacteria. Duration of antibiotic prophylaxis. Antibiotic prophylaxis should not be continued after surgery for the purpose of preventing surgical site infections, including in the presence of a surgical wound drain. This is because one dose of the prophylactic antibiotic should cover the entire period of potential contamination in most cases, and continuing prophylaxis does not offer additional benefit. At the same time, limiting the duration to one single dose reduces the risk of selecting resistant bacteria in the patient's own microbiota and the risk of developing Clostridioides difficile infections. Only in certain cases may a further dose of antibiotic be required, such as for prolonged surgical procedures or when there is major blood loss. If another dose is necessary, the half-life of the antibiotic should be considered. For example, giving a second dose of cefazolin 4 hours after the initial preoperative dose in long surgeries. Half-life of the antibiotics recommended for surgical prophylaxis: amoxicillin's clavulanic acid 1 to 2 hours, cefazolin 1.2 to 2.2 hours, cefuroxime 1 to 2 hours, gentamicin 2 to 3 hours, metronidazole 6 to 8 hours.